Hey, what's up, and welcome back to Basically EMS. Here with my boy Wade, my man, my main man,
Hey.
my dude. That is definitely an equivalent response to how you were just you were introduced there.
Yeah,
for sure.
yeah. Hello.
Ooh, radio voice even right there. That was good.
Practicing
Cool. In the shower at home.
in the shower always.
Yeah.
Best acoustics.
You should.
Yeah.
You should. We could all use it for sure.
Mm-hmm.
All right. So today we're going to talk about something that maybe I didn't really know that there were words for this when I was in EMT or in EMT school. So I'm going to be talking about differential diagnoses of chest pain. So, you know, I don't know if this was something for me. It was more like a medic idea. I don't know about you if that was kind of the same, but definitely something that good to have an understanding of at the EMT level, because you're still doing this. I just didn't know the word for it. So.
Right. I mean, the way I always thought about it was like our rule outs, right? It wasn't until I got to medic school that was like, oh, differential diagnosis is my rule outs, right? Or pertinent negatives findings, you know. So I didn't think about it too deep, I think, at the EMT level, but obviously as your scope progresses, you have to think deeper.
Yeah. So. And this is the big secondary assessment type of stuff that you really need to be into. So I pulled the wiki definition of a differential diagnosis, which I thought was pretty good. So it is a method of analysis that distinguishes a particular disease or condition from others that present with similar clinical features. So essentially when we're talking about this with differentials, it's your patient says they have chest pain. There's a bunch of different things that can cause chest pain. So how are we going to figure out what thing that is?
Right. And then the big takeaway is not all chest pain is heart pain, right? Like a lot of these that we'll talk about are cardiac related, but not all chest pain is heart pain. And that's something that I think at the EMT scope, especially like when they're in school, you know, you're running through a chest pain scenario and then they're like, oh, it's probably going to be a heart attack every time. Right. And like, granted, a lot of these things need a little bit more equipment and maybe a little bit more training to really truly diagnose. But you got to keep that in mind because in the wild, there's a plethora of things out there.
Yeah, that's totally fair, especially as an EMT instructor, right? Like we're going to give people softballs. And just because like, you know, you're not going to expect a toddler to go drive a sports car, right? Like, and that's kind of what you would be asking these new students to like, you know, really be onto these things. So like, you know, in EMT school, you will have a chest pain and it's probably going to be cardiac, some ACS type of thing. But there are lots of other things. And so a lot of this, like you were saying, we can't really say yes or no, but we can rule out things to kind of, you know, narrow down our view. And that's really what this is. So if you're going into medic school or you're going into your FTO and you have a patient and your FTO or your precept or whatever is like, okay, what are your differentials? What they're meaning is like, based off of what you know so far, what things do you think it could be? And so that's what we're looking for here. And then we're going to start saying, if it's this, here's how we're going to rule in or rule out these certain things.
Yeah. And don't get twisted on the word diagnose either, because you're not qualified to diagnose, but you can have theories, right? And so that's above our pay grade, but we can hopefully get enough of the first steps found so that by the time they get to a hospital in front of a doctor, it's quick, bing, bang, boom. They got a couple of tests they're done and now they have the answers.
Yeah. We don't get a diagnosis. We get a primary impression. And that's our number one thing that I think is going on. But without imaging and blood work and all of that we don't have the ability to do in EMS, at least in the US and where we're at, you can't diagnose anything. That's the people that drive said sports cars from earlier.
Yeah.
They do the diagnoses of those things.
Not us. Unless you're driving a sports car listening to this, in which case, good job.
Good for you. Could be cool.
Yeah.
Could be cool.
Yeah.
Maybe stop by Boise and let us hop in and take us for a fun little ride. There's some cool roads out here that'd be fun in a sports car. So we digress.
Yeah. Moving on.
All right. So chest pain differentials. So obviously the first one for us to kind of talk through is going to be cardiac stuff. And the easy peasy mac and cheesy cardiac one is going to be your ACS or your acute coronary syndrome. So this is going to be like heart attack stuff, right? So without making sure that we don't spend the entire time talking about this, what kind of things are we expecting to see that is going to make us fall down the line for, okay, this is an ACS. Like what what signs and symptoms are you going to see when you hear chest pain to make you think it's cardiac origin ACS stuff?
Yeah, I think a big one is listening to your patient as you're asking questions. It's kind of weird when you run so many different heart attack calls and a lot of people say the same exact thing. It feels like an elephant sitting on my chest. I've heard that from people that I'm pretty sure have never met each other. And it's one of those things, like just pressure in general. But that would be the beginning in my mind. And now, obviously, getting more of a history, what were you doing when it started is also going to be a guide. But then just the trademarks, right? I got that left-sided pain moving up my jaw, down my back, into my left arm. Granted, that's going to be more of your male-specific findings. But that one, and male specific, but not impossible for females to experience as well. So that's a big one where I'm already, if I hear like, I got neck pain too coming from it, that's a red flag. And immediately I'm going down that ACS algorithm.
Yeah. I'd say pressure is the big thing. If I hear like a sharp pinpoint pain, I'm probably not thinking it's the heart. I'm probably thinking it's PE or something different. Probably not an ACS thing. I've had the same experience like over and over and over for my STEMI patients. I've heard like, oh yeah, it's a pressure, or not even chest pain, like chest discomfort. If patients are talking about like, I don't know, really, it's a pain. It's just like a heavy discomfort in my chest. Like that to me is like, oh, that's probably. And then like you were saying for female patients, not as common to have those more typical signs, which is why historically women were massively underdiagnosed for cardiac issues. It's not that men, and I think men do have more heart issues than women do. It just is what it is.
Biologically.
But yeah, exactly. But there was an aspect of like, well, they never caught him in women because they didn't say that chest pain and, like rating to the left arm. And so they were like, nope, you're whatever. You don't have heart attack. So I feel like I've heard a lot for women to be more of like between the shoulder blades, like back discomfort. Normally not a pain, but more like upper shoulders between the shoulder blades kind of complaint from them more than the chest. Yeah.
There was a secretary in my high school who ended up having an MI while everyone was at school, and I was an office aide at that time. And so talking to her, she's like, yeah, my lower back is just really bugging me. It doesn't really hurt, but it's bothering me. And, an 18-year-old, I'm like, yeah, you're just old, and it turns out she was having an MI the whole time. So yeah, weird presentations, females and the diabetics are another one we'll get really weird presentations from.
Yeah. So when we're talking about these, this is not like be all end all that if they have these things, therefore they have this, this impression or diagnoses, whatever. These are just the kind of the general things that you should be asking about. So we get it a lot with students of like, how do I do a secondary assessment? What does that even mean? And I think a lot of schools are pretty bare bones on like what their sheets and all that have. Ours is more specific and has some things you can do. Like it has OPQRST listed, all those kind of things. But these are the things you should be asking for a secondary assessment. If they say chest pain, what does it feel like? Do your OPQRST and see where that comes from. What were you doing when it started? Is it exertional? An increase with exertion is really a big sign that it might be a cardiac thing. If the scenario I like to give for students is like, out mowing the lawn is like the typical one I'll give of overweight, older dude mowing the lawn with a history of heart issues, and they start to have pain, because of mowing the lawn, and it gets worse if they're up and walking, right? So exertion's another big one for it to be like an ACS thing.
And then, through medical scenarios, typically there's not a lot of reason to get hands-on. This is one of the few times to get hands-on, and we'll talk about why in a little bit, but it's a rule in, rule out, and it takes you less than 10 seconds to really get an answer quick. And we'll talk about the finding of, we'll come back to it, but just keep that in mind. There are times to get hands-on in medical scenarios.
Yeah, I think kind of on the same thing. Typically, cardiac pain isn't going to change.
Right.
And that's what and we'll get to it later, like you were saying, but if you have your patient move around and those kind of things, if it's consistent, then we're thinking more cardiac than like musculoskeletal or something like that for sure.
Yep.
Other things to look for, this is kind of above the BLS level, but obviously your ECG or EKG changes. And so we're going to be looking for maybe some Q waves, some ST elevation segment changes. So depression, which would typically move itself into, showing some of those STEMI symptoms later.
Which STEMI stands for ST elevated myocardial infarction.
Yeah. So myocardial infarction being a heart attack. The ST segment is, if you're an EMT, right? We have the P wave, which is that first little one, and then we have the QRS, and then the T wave, which is, that's kind of how a normal one looks. And that section between the QRS complex and the T wave, that section is called the ST segment. And so somebody who's having a heart attack, not always, obviously, there are what they call non-STEMIs, but that's kind of what we as paramedics are looking for. If you're not a paramedic and don't know, when we're looking at a 12-lead EKG, we're looking for that area of the EKG to be raised off of the baseline. And so depending on what lead it is, it's 1 or 2 millimeters of elevation in multiple contiguous leads. So if it's widespread, and that would be more like a pericarditis thing where it's widespread and not consistent. But if we have, if it makes sense based off of what you've learned, that's what we're looking for for a STEMI to be able to call a heart attack based off of the EKG changes.
Yeah, I would recommend basics. Now, you can't call anything, but as EMT basics, I think it's a good idea to be familiar with what that looks like. And so if you're near a computer, Google it, look at the imagery, mostly because you want to be able to, if you put that 12 lead on and you can look down and see that already, that things are going to start ramping up pretty darn quick. And yeah, it can get pretty severe to that ST. I mean, we literally call them tombstones because they can get so large and wide, they look like a tombstone. So definitely spend time if you're a basic EMT or plan on being an EMT, just be familiar. You can't do much with it at your scope, but you can prep your medic to be more successful. So ultimately we have better patient outcomes.
Yeah, I have probably said it here a bunch of times. It's one of my biggest things I really try to impress upon my students, but you'll never understand abnormal until you can recognize normal. And so all that we're trying to talk about is trying to find out what's wrong with a patient. And if you don't know what their normal is, you'll never know what's off from that normal. So even if you just know kind of what a normal EKG looks like, when you put that 4 lead on for your medic or you put that 12 lead on and you recognize like that's not what it's supposed to look like. Because, like maybe I'm Wade's EMT and he's like, hey, put that 4 lead on for me. And I'm putting it on and he's over here getting medications ready or whatever. And then patients in VTAC, that's something that we need to manage and treat immediately. If I can recognize that something's wrong and be like, hey, wait, check this out. It looks wrong. It looks wrong.
The squiggles are bad.
I need a grown up. Right? Like if you can at least know that can really save time. Cause I've had, I had a situation where, we had gone from LifePak to Zoll monitors. And so the screen's a little bit different. So I was used to what a normal rhythm would look like and a normal rate would look like on the LifePak monitor. And we put this patient with chest pain on the new Zoll monitor, and I just quick glance over at it. And once you've done this for a while, you can recognize normal pretty quickly. And it was very obvious, like P, QRS, T, looked everything normal, it was nice and narrow, everything looked good. And it was about the normal amount of spikes that I expected for somebody that was like within normal range for heart rate. So I didn't think too much of it. And, start talking to the patient. It's like 3 minutes later, I kind of look again and I'm like, huh. And my EMT's like, oh yeah, his heart rate's like 180, and he just never said anything.
Right.
And so the thing was that cause it was a brand new monitor, it just, to me, the spacing was what I was used to on the different monitor, I think. And it was just new equipment that I hadn't learned yet. So it didn't ring any bells in my head. Right. Where that would have been a great time for my EMT to be like, hey, his heart rate's way outside of the normal range, right? And to notify. So you can do that with EKGs. If it looks real wacky and weird, you can be like, hey man, this is not right. We want to take a look. Right.
And then, worst thing your medic's going to do is one, they're either going to treat it and act on it, or they're going to be like, oh, I'm not worried about it. Right. Yeah. Another reason to know normal, especially as an EMT basic, because you are going to be expected to know how to put the 4 lead on, is know what normal looks like. So if it looks weird, you can kind of troubleshoot too for a second, right? Like, oh, I have the arm and leg swapped or right and left swap, which is a very common thing for newer EMTs because remember, it's patient right, patient left, not yours. That one will throw people off. So if you know what normal looks like, if you have to troubleshoot it, you can look, okay, the leads are still in the right spot. Yeah, this is bad news, right?
Yeah, and then kind of outside of what we can do for ACS, the definitive thing is going to be lab work to look for what troponin levels to be elevated. But that's really I'm sure that there are places that can pull troponin levels, but not most places. So,
yeah, I have heard about mobile troponin testing going out. But
yeah, I mean, there's what was like Minneapolis had the mobile. No, that was Chicago, right? They had the mobile stroke unit with a doctor and the CT. Like there are places that would have this, I'm sure, but not super common out there.
Right. Should we move on so we don't get stuck on ACS?
Yeah, we could talk about this one forever. Next one we have listed is pericarditis. So this typically is going to be kind of a more sharp, kind of global pain, typically. At least that's been my experience. I don't know if you kind of agree with that.
Yeah, I mean, I've only ever had a couple. No true. I'm getting another one mixed up with it, but pericarditis, yeah, it's more sharp pain, and then it's very positional. Is what I've noticed with mine.
Yeah, that's kind of the hallmark sign for pericarditis is when patients sit forward that the pain dissipates. And so that's just based off positioning. Pericarditis is, we have the pericardium, which is the sac around the heart, and pericarditis is an inflammation of that sac. And so if a patient is sitting forward, it takes pressure off of that, and so it relieves pain. So, you know, when, again, talking about secondary assessment findings, it's something you could do. Okay, sit forward for me. Any change in your pain, sit back. Any change in your pain? Nope, that's about the same. Probably not pericarditis. Oh, you feel better sitting forward? Oh, maybe we need to be thinking about pericarditis.
Right. Yeah, I was thinking tamponade was what I was getting mixed up with. Yeah, definitely one that you can look into and make sure.
Yeah, and then like this is again ECG stuff, but like I was saying before, kind of that diffuse ST elevation. So essentially the leads are kind of in an order, and we expect, you know, if it's V1 and V2 have elevation together, that is a sign of a heart attack. But if V1, AVL, and lead 2 that are not connected have elevation, it's probably like a pericarditis thing.
Yeah, 100%.
I don't feel like a lot more to talk about that. But the hallmark, like we said before, is leaning forward and having that relieve the pain.
Another way, like you can kind of double down it together. I was thinking of this word. You can ask them to do that if you're getting orthostatics at the same time. Orthostatic blood pressure. So one while they're lying, sitting, and standing, 3 different blood pressures, and see what the changes look like. But you can kind of mix and match and do a couple things together, right? While you're sitting up, will you lean forward? Does that make it feel better? And then watch your pressure changes.
I will say, I feel like there's starting to be or has been some stuff to refute how accurate orthostatic blood pressures are.
Interesting.
So orthostatics is kind of what we were taught of, like if they stand up and they have a 10-point change down in their blood pressure, 20 points up in their heart rate, they're hypovolemic. And again, this is something I looked into years ago, so maybe that's been refuted. But there is some thought that maybe that's not super accurate, which I don't know. I felt anecdotally like the patients that I expected based off of other things, when they stood up, their heart rate spiked up, like, oh yeah. And then give them fluids and it brings their heart rate down. So I don't know.
Yeah, that's fair.
But that is what orthostatic blood pressures are for, essentially. Aortic dissection. What you got on aortic dissection?
Aortic dissection. So not to be confused with aneurysm, though they are very similar. But with those aortic dissections, we start to have the tearing of the layers of the aorta. So you start to get like kind of a ballooning off. It is like a similar to an aneurysm, like I was saying, but more in the weeds as to the differences. Big one, though, is if you hear shearing, tearing, ripping pain, that is a key indicator, right? This is where listening to what they're saying is so much more important than just asking questions, because that answer can guide you one way or the other. And with the next big finding, you know, if you hear, I got chest pain, what does it feel like? Oh, it feels like something ripping in my chest. All right, let's take some blood pressures and maybe we try on both arms. Let's see if we get differing values, because that's going to be another key indicator there. Reason being is because the blood has to circulate a little bit extra because it's now fighting against that ballooned portion. So you will see potential differing blood pressures.
Yeah, I've had one patient, and I might have told this story on the podcast before, but I've had one patient I know confirmed and everything, and I saw the unequal blood pressures, and it was I don't know, it's a big frustration to me as an EMT of a medic that didn't know these things and did not key in when they were hearing this and did not trust me, even though I was like FTO 3-year EMT, like, you know, he knew my name. I'd been around, you know what I mean?
Right.
But still didn't put any trust in when I was saying, dude, I have no radial, I have no brachial, I can't find a blood pressure. And so I was on the patient's left side trying to find blood pressures and pulses and could find nothing. And I still remember telling him, like, hey, I've got nothing over here. And he was fiddling around on the right side. Or no, sorry, I was on the right. He was on the left. Fiddling around on the left arm, trying to look for an IV. Reaches down, feels the radio, like, and she looked like death. She was pale as a sheet. Reaches down, is like, oh, I've got a radial pulse over here. And like, even then I was like, bro,
that's a red flag.
Are we not concerned about this? And I like looked at his medic partner, and he was like, because it was the fire captain that was like, you know what I mean? So, it's just that weird situation.
Yeah. Boy.
But yeah, patient had a great pulse and everything on the left side. But when we finally turned the engine off, because it was a diesel engine, so it was loud, I checked the blood pressure in the ambulance bay. It was like 50/30. She died like 5 minutes after we got her to the hospital. But yeah, it was the one time I've seen it, and it was stark. And it was not the only thing. Like, she had the complaint of the ripping chest pain. She looked so bad. She was so lethargic, super weak, super pale. Like, it was a lot going on for sure that you could see.
Did you ever get a pressure on the good arm?
No. The captain literally laughed. When I got the blood pressure on the other arm, he's like, oh, you really got to get that blood pressure, huh? Like, he was not concerned. Just, it totally went right past. It was, I think just 20 plus year arrogant, been around, doing this since before you were born kind of a guy.
Jaded, salty.
Yeah. So didn't really believe that I couldn't find anything, and just kind of laughed. So we never got, like, he didn't try to find a pressure on his side. And we didn't use auto cuffs or anything. So, there's none of that going on.
I mean, presence of pulses, though, is good. That's good clinical judgment, though, off that.
Yeah.
Work around it.
I know, a bit of a roundabout story for aortic dissection, but that is a significant finding if you have those unequal. So first thing you should do if somebody says they have ripping chest pain, it's real easy to reach down, and we teach a lot of the time, especially with trauma, to check both sides at the same time. Just check both radials. Make sure they're equal. If they're unequal, then that could be a significant finding for you.
And when we're saying equal, we're not talking just about rate. We're talking about pressures as well.
Yeah, they should be as strong as each other or as weak as each other.
Correct.
One should not be significantly different than the other.
Moving in, myocarditis.
Yeah.
Right? So I really like this. I was telling Chris earlier, I like this word, viral prodrome, which means it's basically a viral infection that's the precursor to this condition. So it's the leading symptom or the beginning signs of this. But myocarditis is a heart infection causing inflammation of the heart muscle itself. As far as the causes go, it can be pretty broad. I was telling him earlier, I had a patient who was a viral myocarditis. He got sick over on the East Coast when he was in the service, and ended up having some pretty extensive cardiac history at 28 was when I met him the first time. And yeah, it can be a pretty big deal, right? And so this particular individual had gone in and out of like VTAC and had coded several times. And so you just never really know. If it's something viral borne that's affecting muscle, you can have some odd presentation with it, and you can have some weird progression with it too. But understand, if it's cardiac in nature, it's likely going to be a cardiac progression.
Yeah, this one I don't feel like is something we're going to see very much or be able to like really be like, oh, this is probably a myocarditis thing, right?
It's one maybe just take note of the history on it, and then maybe just keep a closer eye on the circulation portion.
Yeah, for sure. So look for those, those kind of viral signs and symptoms kind of a thing, right? Because maybe it was something like that, and then the fatigue and all that to be building up. But yeah, it's a little bit hard because the chest pain probably is kind of, again, a more diffuse kind of a chest pain.
Right. They need imaging done for confirmation of enlargement of the heart, abnormal, because there's a lot of different enlargements of the heart, potential issues, I guess I could say. But yeah, they're going to need labs. They're going to need imaging. There's nothing that we can definitively do out in the field, at least not here right now. Not to say that couldn't change in the next 10 years, but just keep that in mind.
Yeah. Yeah, that's what we have for cardiac stuff. This is definitely not fully encompassing of everything that could be going on for patients. But, some good ones for you guys to have in your head of, things I should be thinking about. And questions I should be asking essentially. So
yeah, I like to think of it as like anytime you have a chest pain or any call in general, cast a wide net of potentials. There was one medic that I worked with, and she really burned this into my head, and it used it a lot of, on the way to the call, this is a chest pain. Okay, before we even get there, what's 5 things it could potentially be? Cast that wide net. And then from there, you can start gauging your questions to rule stuff out, rule stuff in, right? But we're just giving you more options for that rule in, rule out, essentially.
Yeah, for sure. All right, let's move to pulmonary. So the first thing we have here for pulmonary is going to be pulmonary embolism. And so that's going to be a blood clot in the lungs, essentially. So my anecdotal history of patients with PEs is this, from what I have seen, is usually pretty pinpoint or like really relatable pain that they can say my chest hurts right here. And it tends to be, from what I've seen, more sharp. I don't know if that kind of matches with what you've seen.
Yeah, I've had a lot of different, the textbook the textbook presentation of PEs is pinpoint chest pain with a low SpO2, clear lung sounds, right? Because it's not really a lung problem, it's a clot problem in the lung. But every PE patient I've had has had a weird presentation. Like the last one I had was like super sharp pain, but in one shoulder. Huh. And it was, I don't know if that was a back of a circulation or what, but I've never had that true pinpoint on my chest pain. But I have had several PE patients. It's just people present different based on their own anatomy.
Yeah, weird. So again, as we were saying, none of these are hard, fast rules, right? Like we're talking about the general presentations, but it could be anything at any time, right? We just need to always be ready for the next thing to pop its head up.
Yeah. I think it's important to talk about some pre-existing conditions or things that'll lead to PEs. A big one is that stagnant lifestyle. People who are typically not moving, because if you're not moving, your muscles aren't helping to circulate blood. So you start to have that coagulation. So clots start to show up. So questions to ask, have you been non-moving for a while? So long road trips, long flights. Have you had any recent surgeries because your body's already trying to make clots? Big one is oral contraceptives, though. That is a big one. My wife had a patient who, I think she ended up having like 16 PEs because she had swapped her oral contraceptive like 4 times in a 3-week window. And so, just trying to find the one that worked. You're supposed to wait a little longer than that too, I'm pretty sure.
Yeah, follow the doctor's orders.
Yeah, so I think she survived, but she was, exact words from the doctor I was talking to about it was riddled with them, just full of PEs. So I gotta be careful, right? But this is one of those easy, okay, chest pain, let's start listening to the questions. Maybe we do a little bit more on the assessment side.
I got another PE story that I'll tell after we talk about it. Kind of a little bit similar. Oral contraceptives, especially smokers. That's another big, risk factor for PEs is going to be smokers. So this is something you really, if you have, especially like a younger female patient, this is who you really need to be thinking like, okay, cool. Do you take birth control as an oral birth control? Are you a smoker? And then you're like, oh, any long flights recently? You've been sitting down due to road trip, like all those things are pointing towards it. These patients are typically going to be dyspneic. They're going to have difficulty breathing. And if we think about what's going on in the body for these patients, right? There's a blood clot that gets stuck in the lung tissue. And so all the blood circulating that should be circulating beyond that blood clot no longer is. So all that lung tissue is no longer being recruited for gas exchange. So they're getting the air in that they're supposed to, but there's no gas exchange happening in that segment of lung tissue. And so their blood oxygen is going to drop. Depending on where that clot is and how big it is and how much, lung tissue is taken out, it could be significant, it could be minor. But typically they're going to be a little bit short of breath because they are not meeting their oxygen demand like they normally would because there's not as much lung tissue being used. So, but the flip side of this is there's nothing mechanically wrong with the air movement, right? The ventilation is still all normal. So when we check lung sounds, that air is still going in and out of the lungs normally. And that's when we listen to lung sounds, we're hearing that air passage. That's not being affected or changed. It's just that blood supply. And so the gas exchange is being affected. So like you said earlier, clear lung sounds, normal lung sounds with a low SpO2 and dyspnea and chest pain is pretty hallmark for PE. So if you have those things, we really need to be thinking about it. And for me, when I have a chest pain patient, they say they have chest pain. Second question all the time: do you have any difficulty breathing? To kind of rule those things out, because it could be, chest pain secondary to like a CHF or a PE. And so trying to ask about that dyspnea or that difficulty breathing, I feel like is really important.
Yeah, that's part of that VQ mismatch. Is kind of where Chris was going with it, right? The person can bring air in, they just can't use the air. So it's a Q problem, not a V problem. So if you're, in school tracking what VQ would look like, PE is a good example of that.
Yeah, definitely. A little story about it. So, it was kind of weird when we got called out to a patient, and family members had walked into the house and found him like semi-conscious in the hallway laying there. And we start talking to him, and he's just super, super out of it. And the fire department knew him. They'd been on him before, and they're like, yeah, this isn't how he normally is. And family's like, well, he kind of has a history of drug abuse, but we lock up his meds. And so he doesn't have access. Like, we hand his meds out to him. So I don't think it's something like that. We're like, well, maybe he got into him. And they're trying to do like a medication reconciliation to see if maybe there were more missing, but they weren't really sure. And he was just, just a little bit out of it. And his SpO2 was low. And so, get him in the back of the ambulance. We start going, do an IV. And I put a non-rebreather on him, and he's just not handling a non-rebreather. He's just ripping it off, and he's fighting me really hard with it. And so finally I'm like, I need to be able to ventilate this guy. I'm going to give him a little bit of Valium or Versed, some sort of sedative. Like, I need him to be able to get more oxygen in, and he's not letting me give him oxygen. So, maybe I wouldn't do this now as a more experienced medic, but as a new medic, I was like, I'll give him a little Versed, and it seemed like it worked great. Like, he calmed down. I was able to keep the oxygen, the non-rebreather on. His oxygen level started coming up a little bit. I think they were still like high 80s, but started to come up a little bit. Everything's looking a little bit better. And we get to the hospital, and we move him over, and it's like me, my partner, patient's wife, and somebody, I don't remember who it was. It wasn't the nurse. It was another, maybe the RT. I don't remember. Somebody else happened to be in the room. And so, we're moving over, kind of talking to whoever was in the room. And the wife is like, guys, he doesn't look right. We look over, and he's like fully unconscious. So we check, and he's pulseless. So we start CPR, and, doing CPR, crash team comes in, whatever. They start working him. And after a couple minutes of me telling the doctor the story, whatever, they give some Narcan. And next pulse check, patient has a pulse. And I was like, brand new medic. Yeah. I was like, I killed him. Yeah. That was me. I did it. I killed him. Whoops. Like, he had taken a bunch of opiates, and I gave him a benzo, and I just that was, I killed it. I was like, I was just wrecked for a little while. Right. And then like a minute later, I hear like code blue or whatever over again. I was like, oh, good. It wasn't me. Something else happened. It wasn't me. And so they start working him, and I think we had left and came back, and later the doctor said, like, yeah, just a massive clot storm. Like, that was the terminology she used. Like, she's like 30 clot, just whatever happened. There was a massive amount of PEs. So they gave him, like clot busters and everything. And he survived, and he was okay. But, that was like the first time really where I was like, I killed my patient by my treatment, and if you're listening to this, that is a common thing for us to, obviously hopefully nothing purposefully. Yeah. But, there are going to be times where you follow down a path and everything makes sense, and you're wrong, and something happens. And that was a time where I thought I had done something really bad. And thankfully for me, that wasn't the case, but yeah, that was fun.
Well, you're always scrounging too. 'Cause then, like, when something happens, you're like, oh, did I have all of the pieces I needed before I made that choice? Like, if you wanted to watch our podcast with, Mr. Mike and Mr. Casey, I talked about a mistake I made with a, third degree in atropine. And that was one of those of like, if this guy dies, this is probably my fault. And I overworked this guy's, and I think he made it too, but it was one of those of like, you never know. And we're playing with people's lives a little bit sometimes, and not because playing might not be the right word, but we are trying to influence an outcome. And sometimes in doing the most that we can do, we do too much in the wrong way.
Yeah, at the end of the day, we're working with limited resources and trying to do the best we can. And sometimes we are going to make mistakes, unfortunately. So
line of sight medicine.
Yeah, I thought this was my time, but thankfully, thankfully it was not. I was fine with it, what I did.
Yeah. Okay.
Cool. Moving on. Pneumothorax. So hopefully, if you're listening to this, you know pneumothorax is a collapsed lung, right? That's the layman's term for pneumothorax, essentially. So for this, what we're going to be looking for, they can have some chest pain, and we're going to be looking for unequal lung sounds. So the affected side will have typically diminished lung sounds, especially depending on kind of how the pneumothorax begins and whatever, but a lot of the time more like axillary, especially, we'll start to have those diminished lung sounds. So we're looking for that chest pain with those diminished lung sounds. They may be dyspneic. They may have a lower SpO2. Where we see here the difference between PE is PE's clear lung sounds. Here we have abnormal diminished lung sounds.
Right.
And then later stages, you might see some JVD, some tracheal deviation, and maybe some hypotension as well with a pneumo.
Yeah, you might even have like unilateral chest rise, but the best way to confirm that is with lung sounds. But if you walk in and you see like that guy's chest's not moving normally, that's already keying you, and you should listen to this person and just confirm. But yeah, diminished or absent.
Yeah. And it is important to remember that typically when we talk about pneumo, we're talking in a trauma situation, but there is a possibility of spontaneous pneumothorax. This is especially true for very tall, very thin male patients, especially, again, if they smoke. That's another big one. So I'm sure you've had it before. I've had it where I tell a class that and like, and then the 6'4", 19-year-old who's 155 pounds raises his hands like, oh yeah, I had that before.
Yeah.
You know?
Or like everybody turns and looks at that guy at the same time. Yep.
Yeah, I don't know if it's just like connective tissue growing too quickly or what it is, but that is a kind of a risk factor or a patient population that we might see spontaneous pneumo in.
I've heard another theory was that because they're so tall, they can paper bag syndrome themselves. So if they take a big breath and there's any sort of contact, whether they bump into something or whatever, especially if they're smokers with weak lung tissue, that could be another potential cause. But there's a lot of potential reasons.
Yeah, but yeah, just that patient to look out for if you have. You wouldn't expect a 22-year-old to have a heart attack, right? So if they have chest pain, really be careful about those lung sounds. Look for those signs and symptoms.
Yeah.
My understanding is typically spontaneous pneumothorax is going to be more self-limiting than like a gunshot wound or stab wound to the chest or something.
Yeah.
So you might not have those really pronounced things, but it is possible for that to happen. So make sure you're aware of it.
Yeah. Anything we say is one of potentials because people are different. People's anatomy is different. People's where their body functions all similar but slightly different. So you just never know. So just take everything we say with a grain of salt.
Yeah. Working down pneumonia.
Yeah, pneumonia.
Tell us about pneumonia.
Yeah, so it can be a number of different causes, viral, bacterial, fungal even. But essentially it's just a gnarly lung infection that is typically the progression of a pre-existing condition, But yeah, it can cause some discomfort on those breaths there. Depending on what's in the lungs, typically the lung sounds will differ. I've had a lot of like rhonchorous pneumonia patients. I have had a couple of crackle patients, but that was more of like a fibrosis type thing going on. But yeah, and where this is going is difficulty breathing because a lot of times, even at the protocol for the agency we worked at, EKGs were part of the shortness of breath protocol, just as a rule out, but also because a lot of these, like we've discovered, a lot of these could potentially have some involvement with difficulty breathing, right? It's the same thing moving away. We talked about heart, but like if someone has a broken rib and they go to take a deep breath, it's not going to feel good. So they're going to be kind of limiting. Same principle applies. If their lungs are having a hard time functioning, the expansion of the lungs is going to create some discomfort.
Another big one is going to be a cough. That was kind of my go-to. So fever and cough are big. Especially if you have that chest pain and you're kind of on the fence of like, is this like a CHF or is it a pneumonia? Because crackles and rhonchi, thank you. Crackles and rhonchi, I was thinking rails and rhonchi, I just couldn't get there. Can sound very, very similar, especially you have a 300-pound patient. Like it's so hard to tell the difference between the two. So look to see if they have a fever. That can be really, really helpful to differentiate. Or if they've had any like flu-like symptoms, cold-like symptoms recently as well. And then productive cough. So
hacking stuff up.
Yeah. And typically the worse it is, the darker it's going to be. So if you have a patient who's been coughing like a dark, sludgy, brown nastiness out, it's probably going to be from a pneumonia thing.
Yeah,
so
they've been sick for a while.
Yeah, it's progressed a little bit. So make sure you're looking for that when we're talking about it.
Yeah.
I do have on here something called agophony, which I'm assuming that's how you say it. I've never heard this word before. I was researching this. Yeah. But it is a resonance when auscultating the lung sounds that makes the E sound like an A when you're listening to lung sounds and patients are talking. And it just has to do with like the frequency of those letters and like the vibration frequency of those letters, and like the packed lung tissue changes those E to A sounds. So it sounds kind of weird. I think it's way beyond what we would ever do or care about, but I just thought that was kind of cool. So
we're trying.
You can listen to lung sounds and have the patient talk and see if they sound, reading through it to me, it sounded like maybe it would sound like they were underwater a little bit. So that's another thing you can look for. And it just shows that that lung tissue is kind of packed with sludge.
Right. I mean, definitively, they're going to need an X-ray. That's going to be what shows. If you're curious, those are some neat looking X-rays too. Even the layperson like me who barely knows what I'm looking at these X-rays, when you see that big white pneumonia cloud in the middle of the lung, it's like, I'm no expert, but that's bad right there. So yeah, I mean, this is all once again going to be a field differential as a potential thing that could be going on, but just don't be alarmed if you have a pneumonia patient presenting with some chest discomfort, because it's a lung problem in the chest.
Yeah. And that chest discomfort might be as simple as they've been coughing for 2 weeks and now their chest hurts, right? It could be something mechanical, really simple. Doesn't necessarily mean it's going to be something in the chest. It could be something really basic.
Right. And then, that's a good point you bring on, like with people coughing, especially older folks and like, the nursing home type environments, they cough a lot. And so they're going to be sore because they get sore easier. And so I typically have seen a lot of pneumonia in older folks. I've seen it in younger people too, but old people is the typical stagnant lifestyle, living in their nursing home, watching their stories. Yeah.
The stagnant lifestyle, especially, they're not going to be moving around to clear that stuff out. So they tend to do a little worse, where you'll hear about walking pneumonias with younger patients, but not typically with the elderly patients.
You got to walk a lot to have walking pneumonia, turns out.
All right, moving down, let's talk about some GI stuff. So GERD, gastro esophageal reflux. Thank you. So heartburn essentially is another one. This one, what we're going to be looking for, typically this is more of a burning pain. If you're listening to this and you've had heartburn, you know exactly what I'm talking about. But it's typically more of a burning central pain, kind of up into the throat. And it's usually worse after meals. For me, it's like really acidic meals, especially if I eat too much. If I go have like pizza, like pepperoni pizza that has like the pepperoni and like the tomato sauces for me are bad for my acid reflux, but especially if I eat a lot of it, it will tend to give me acid reflux and I'll get that burning sensation. And it tends to be a lot worse laying down, especially on the right side.
Interesting. Laying on your right side?
Yeah. And it's the same as like, if we have the recovery positions on the left side based off the position of the stomach, right? It's on the left side of our body. So left side puts it below the level of the esophagus. Same thing with like GERD. If you're laying on your right side, it allows that stomach acid to spill, where if you're on the left side, it kind of
that makes sense. Kind of aligns the pipes a little better. Yeah, that's fair. Same. Like, it's so sad. Pizza, wings, and beer is like my favorite, and now it's like give me my Tums first, and then I'll get after that.
Yeah, it's because you're in your 30s now.
I know.
You just can't do it anymore.
Sucks. I will say, though, is that, and the reason this is in this chest pain is that I have had MI patients whose only complaint was GERD-like symptoms, and they were having a heart attack. So it can be confusing. Now, majority are pressure in my experience, but you do get the outlier from time to time. This is why we're talking about it now.
Yeah. Let's make it clear that when we're talking about these things, right? The game that we play in EMS is worst case scenario, not best case, right? So if I'm working out there and I have a patient that is complaining of chest pain to me, I don't care if I think it's a GERD thing. They're getting an EKG.
Yeah.
So I can at least do that. Maybe I'm not going to do aspirin and nitro because, I'm not seeing any changes there, whatever, but at the least for me, they are going to buy themselves an EKG so I can make sure. Because the worst thing you can do is be like, no, he's fine. It's just GERD. It's just GERD, whatever. And then you go and the doctor's like, did you do an EKG? Nope. And the nurse puts on the EKG and they're having a massive STEMI. Now now you look real dumb.
Yeah. We've all looked dumb before, but that's
Yes.
a different kind of look dumb. That's
Yeah.
a feel bad and look dumb.
Yeah, there's looking dumb because you don't know better, and there's looking dumb when you should know better, and this is when you should know better.
Yeah, this is one of those that I've seen medics like pawn off.
Mhm.
It's like, it's just GERD. I'm not going to do anything. It's like, due diligence goes a long way though.
Yeah. Yeah, and if you're the new medic, like, so what, you have to write the chart now? Like what?
Yeah.
Why are you going to pass this off to your EMT? Like for what reason? That is not quality patient care.
Right.
So
100%. And you got to click 10 more buttons. Oh no.
Yeah. Boo-hoo, no big deal. So, definitely, keep in mind we're trying to figure it out. That doesn't mean that we're diagnosing anything. So all the signs are leading towards GERD, but just to be safe, I'm going to throw this EKG on and just rule, because again, we're ruling in, ruling out, and that's ruling out an MI. That's ruling out ACS.
Right. And a lot of patients who have GERD will tell you, I have GERD. It feels exactly like it.
Yeah.
Same thing. I'm still going to look. I got to look. But, if it looks like a duck, sounds like a duck, I'm going to call it a duck most of the time.
Typically,
but due diligence goes a long way once again.
Yeah, for sure.
Cool. Esophageal spasming and rupture.
Yeah. Can happen. This is incredibly rare.
Yeah.
But it can happen, especially like consistent vomiting over and over. Your esophagus just tears. So that can cause kind of some throat chest pain.
Kind of like a Mallory Weiss type thing.
I think that is esophageal tear, right? I think it's
It's graded and there's more to it.
So not a lot that we can do here. It's going to be, they're going to have difficulty swallowing or eating anything, even like swallowing normally, there's going to be difficult for them. And then some kind of, usually like a tearing pain in the throat. But, we're getting into the weeds a little bit here.
Right.
Like, you'll probably never see this kind of
stuff. I would say with this one though, is location, right? Like chest pain, this one, because if it's going to be a true esophageal spasm or tear, depending on where it's at, because Mallory Weiss is more the sphincter of the stomach and the esophagus there. If it's more of like a Mallory Weiss situation, it might be lower than the chest. Just some people don't know what to call it, right? Like, it's chest pain, but it's like, it's just south of the sternum. So it's not really, just get hands on, do some due diligence, do your looking.
Yeah. Last one we have for GI is going to be pancreatitis. And so this will be typically more of like an epigastric pain. So not so much, kind of the same thing you're talking about, not so much chest as it is like upper abdomen, kind of around like the xiphoid process area. So you might have some pain there, maybe some nausea. But again, this is the kind of thing where, are we going to see it? Probably not. It's not, I wouldn't say pancreatitis is super common, at least like new onset that people wouldn't know they're going to have it.
Yeah. I mean, and a big one, I've seen it a few times, and I've seen it in mostly like alcoholic populations.
Yeah, that's fair.
And so it's one of those of like, ask your questions, and pay attention to your surroundings. I had a pancreatitis patient who's like, I found out, there's a whole lot of backstory to this, but I found out from the crew that we relieved that he was likely going to call again. And sure enough, he did. So we can see the call notes of, they were just there. And I asked him, I was like, you had anything to drink since you went to the hospital at 3 a.m. this morning? He's like, no. I was like, cool. Well, what's that half drank bottle of vodka at your feet? And he's like, well, that's just today. I'm like, okay, well, that still is part of the question that answers the question. And he was having a massive flare up because of the alcohol, right? Because forcing insulin production, all the things. But yeah, so don't be surprised. It is going to be typically more epigastric, so just south of the xiphoid process there. But it is very generalized pain, and they will be holding their rib cage a lot of the time that I've seen.
Interesting.
Yeah. So don't be shocked.
Cool. Let's move on to musculoskeletal.
Yeah.
So we'll kind of skip on the notes, but the common one more is going to be like a rib fracture thing. So this is one of those ones that you were alluding to earlier, where this is typically going to be more like a reproducible pain. So as well, we'll feel around. Does that hurt? Make it better or worse? And that makes it worse when you're touching.
Right.
That's a more common thing. And then a lot of like the traumatic stuff is just going to be based off the story. Any falls recently, anything like that. Did you bump yourself into anything anywhere? And that will kind of lead you maybe to thinking it's going to be like a musculoskeletal thing.
Yeah. Definitely listen to the story. Make sure you're paying attention to the surroundings, because if it's something like a wreck, like a car wreck, is it impossible for an MI? Absolutely not. Is it likely that that rib pain, or it's going to be rib pain? depending on the situation, right? They hit their steering wheel, whatever. But yeah, and they're going to have some pretty excruciating pain. And like Chris said, this is reproducible. The way I frame it for his students is, I have chest pain. Okay, push on your chest. Is that better or worse? Oh, that's way worse. Okay, well, I'm not thinking cardiac at this point because I'm not touching your heart, right? I'm touching something that if it's giving me a pain response, it's likely the problem.
Yeah.
Or at least a clue to the problem.
Yeah. Another thing with rib fractures, typically some dyspnea, and that's just because it hurts so much to take a deep breath. They're taking shallow breaths. So typically SpO2 is going to be fine. They're just feeling a little short of breath, and it's not so much that they're short of breath. It hurts too much to take a big breath, so they're breathing more rapidly.
Right. They supplement quality breaths with quantity of breaths. Like I can't give you 12 good ones, but I can give you 20 okay ones. And so that's
still enough oxygen to keep the levels up.
Right. They find the balance. Yep.
Another thing you can do with this one too is have put your patient through some range of motion stuff too. And I had an elderly patient that chest pain, whatever, and nothing was really clicking. And once we started having him move around, he's like, "Oh yeah, I put my hands up, that hurts. I move, I do this and that." And come to find out that the day before, I think it was, he had done a ton of gardening and normally really sedentary, doesn't get around and move around. And once he had said that, I was like, "Oh. Well, I was moving the hose all around," and he was old, and so he was just sore. It was just a muscle soreness, but never would have known unless we had him do those range of motion drills. So that's another thing you can do to look for that reproducible pain. You can do your palpation. You can also have them do some range of motion and see what you have there.
Yeah, that's smart. That's a good one.
Costochondritis.
Yeah.
So inflammation of the cartilage that connects the ribs to the sternum. So kind of similar thing. It's going to be more, obviously sternal pain, or pain over the chest, more reproducible. If we palpate along the sternum, is it making it any worse? Maybe a little tenderness there.
Yeah. Yep. Not a whole lot to add to that one. This is one that could be a little bit more acute, but typically this is something, there's some sort of precursor. They're going to be aware to a degree that this is happening. If they're not, still going to do the full meal deal, run them through the tests.
Yeah.
Want to move to neuro?
Yeah, I think we can skip the first one that we have here.
Oh, I think it's an interesting one.
Oh, no, go for it then.
Herpes zoster, otherwise known as shingles. This is an interesting one because it is very superficial pain. It's a nerve-related issue. So if you've ever had chickenpox, the chickenpox virus lives in your nerve endings. So if you've had it before, you are susceptible to get herpes. You are susceptible to get shingles later down the road. But it's an interesting one because it does cause chest pain, but where you'll see it is it causes like a rash. But where it's kind of neat is that rash will follow the nerve endings. So like you'll see a line across their body of this they become sores. They get pretty gnarly and they're extremely painful. So I've heard. But I think it's neat just because you can see the nerve outline. It'll literally outline the nerve that is the problem point. But yeah, it'll cause chest pain depending on where it's at, but different people get it in different places. I've heard of people getting it on their face before, which sounds terrible.
Yeah.
My dad gets it in like his armpit. He'll get it like on his rib cage. And it's just like it's a rash looking deal. And talk to anyone who's ever had shingles and they'll let you know how bad that sucks.
Did you have chickenpox as a kid or were you chickenpox vaccine?
I got the chickenpox.
Did you?
Yeah.
Yeah. This is something that's kind of interesting. You're going to see, especially, I don't think people will be listening to this in 20 years, but as time goes on, there's going to be a certain age where, people had the chickenpox and are going to be more prone to this versus people that had the varicella vaccine that, as far as I know, helps to stop this, right? And there is a shingles vaccine that people can get that had chickenpox, but there might be some difference in patients' ages as far as who this is going to affect based off of those things, because we're both old enough in our 30s that we had chickenpox, and so we're going to be prone to this, where somebody who's younger that didn't have chickenpox might not be susceptible to shingles. So
yeah, we're victims of our age.
I know.
It's fine.
Yeah. Is it?
No.
I got like almost 10 years on you, so I don't want to hear from you, young man.
Yeah, that's fair. I'm still sore. Cool.
Last one, and I almost don't want to talk about this because so many people fall like right into like, this is what everything is just going to be like an anxiety thing. Yeah. And I think you can tell probably by both of our tone of voice that like we've seen too many people just be like, that's anxiety. Right. Oh, it's a 25-year-old female patient, it's just anxiety, right? And not do their due diligence of like, well, maybe it's not. Maybe it's a PE, maybe it's something else going on. So You can have that hyperventilation. My chest feels like everything's squeezing and crushing down, and claustrophobia kind of feeling and all that from anxiety. So that is a possibility.
And the palpitations in the chest as well. So they start to have that fluttery feeling, and that's unnerving anyway.
Yeah. Oh yeah, for sure. Could it be this? For sure. Is it this? Maybe. But again, that doesn't mean that just because whatever factors are at play, we shouldn't do our due diligence on everything else and listen to those lung sounds and do an EKG and, all those things. We still need to be doing a thorough assessment on this patient. And a lot of the time to me, anxiety is kind of the last thing I fall upon of like, all those other things aren't checking out. Now I'm listening to the story. Oh, they went through, recent hardship in their life. They lost their job or they were going through a breakup or whatever. And all these compounding factors. Okay. Nothing else is checking. They have this personal life stuff going on. Maybe it is an anxiety thing. They have a history of anxiety. They don't have their whatever, right? Like, but it's definitely not at the forefront of my mind. This is, exclusionary kind of a thing.
Well, it's one of those things too that like, I feel like it's like neuropathy. People just downplay it as like, it's not real, right? In anxiety or panic responses, one of the things that happens is your pons takes over your respiratory drive and it goes into fight or flight mode. That's what your pons does. And so this is a very real experience to this person and it's having very real manifestations. Now, is there a physical or medical cause to it outside of the anxiety? Probably not. But you are doing such a disservice to that person and your patient and your career reputation if you don't give them the chance to at least hear them out and do your job, right? Because it's so frustrating when you show up in the first 5 minutes, the medic turns, it's anxiety. You don't know. I've got other choice words I would use in a different environment. But it's just so frustrating. So I think ending with it is probably the right place to put it, just because it should be the last thing in your mind, unless there's something totally screaming out that, like I have an anxiety disorder and I forgot my meds and I haven't replaced them and I'm anxious right now. And like the story has to line up, but don't just walk in and be like, it's probably anxiety, because that makes you a poor provider. Yeah,
for sure. And then recognize, just kind of like you were saying, like, I didn't know how bad it would be till I went on my first like real anxiety attack patient that's like in the corner, nobody can get close to them. Like it can be pretty significant for people, right? Yeah. So again, don't just discount, even if it is anxiety instead of a heart attack. Like it can be a very significant thing. Right. Is it life-threatening? No. But for them in that state of mind and that time, it is a very significant, difficult thing. And so, there's not a lot we can do as a medic. We could, give some benzos or something, to bring their anxiety down. But even as an EMT, being able to talk and listen, really more than talk, it can be really helpful. So don't discount the anxiety
It's
attack.
Not your job to judge their emergency. It's your job to show up. And that's what a lot of people forget.
Boom. I don't want to drop the actual mic.
I would think about
these are nice. I don't want to hurt these.
Cool. Well, I think that we covered a pretty broad list.
Yeah, I think that was pretty good. The big takeaway I think for everybody listening to this is just do your thorough assessment. And I think what you said earlier about when you're driving to the call, think about what it could be and start to build that list and then start to knock those things down, right? My first priority is always going to be heart attack. I'm going to ask questions. No, that doesn't make sense. Okay, what's my next thing? Maybe it's pericarditis. Okay, let me check that. I know no change when they lean forward, so probably not and work your way down. That's the purpose of this. Yep. And I'm sure we'll do more episodes down the line about it, but this is not just for chest pain. You should have differentials for all your major complaints, right? Shortness of breath, we could go, I'm sure, the same length about shortness of breath and what could be going on there.
Same with GI.
Yeah, exactly. So make sure that you are recognizing that, this is a process and we're just trying to show you kind of how the process works. So secondary assessment is a process. Do your differentials. At the end, you should have your primary impression. After you do your assessment through your differentials, you'll have your primary impression, and that's what we're going to act upon for our treatment plan.
Right. And remember, as your scope expands and the more things you can do, this list gets bigger, right? So this is not the end all be all by any means. It's just an introduction to the concept. Now you need to take that and run.
Yeah, for sure. Cool. Well, hope this was helpful for everyone listening to it. As always, subscribe, like, do comments, all that stuff.
The comments.
How does Wade's facial hair look today? I want to know what people think about Wade's facial hair today. So
be kind.
So leave that in the comments if you would. And yeah, like I said, hope it's helpful. We'll be back in the next couple of weeks for another one to talk about something different. We'll see everybody or talk at everybody then.
Yes, sir.
Wade Finger Guns.
Bye.